So we want to thank our in-person audience as well as the many folks who've been attending virtually online for this year's Future of Pediatrics program. We are now down to our last clinical presentation. We'll have a very short summary on the other side of this, but it's my pleasure. I love using the line last but not least, actually. We have Dr. Randall Burd, Chief of our Division of Trauma and Burn Surgery, who is going to talk to us about practical, value-based approach to common pediatric surgical problems. Dr. Burd, take it.
I guess I have one disclosure. I thought my talk was going to be an hour and a half, so I have 75 slides. So my job is actually, yeah, I'll make it a little faster. My job is actually easier. You guys make my job easier. I'm a one diagnosis guy. When I go to see a patient in clinic, somebody's already put on the chart something that I need to see, and I just have one diagnosis I need to deal with. And you have to filter through a lot of diagnoses to get that patient to see me. So thanks in advance for making my job easy. And we want, when trying to decide whether to take care of something in your office or send it to me or do the referral, I think that thinking about quality and value are two things. Can we by seeing the patient quicker have better value care? Is it better for the patient to be treated in the office? And I'll give you some examples of how we can measure this balance. And so, nice study looking at patients seen in a pediatric surgical clinic and judging whether or not, in retrospect, whether these are appropriate to be seen in a pediatric surgical clinic. And the definition was, did you file AAP guidelines for that referral? And was it a diagnosis that required a surgeon to diagnose or treat that disease, basically an operation? And this is how they defined appropriate and inappropriate diagnoses. These are the risk factors for inappropriate diagnoses and multivariate analysis in non-pediatrician mid-level providers and then certain patient characteristics. But I think most interesting in the studies, they looked at the diagnoses that they saw in the office, and there is two winners. There's two prizes given for the most common inappropriate referral diagnosis. And the highest percentage to take a diagnosis that had the highest percentage of inappropriate referral. What do you think the winner was? Number one for both of these. Umbilical hernia by far. So the American Academy of Pediatric Surgery, American Academy of Pediatrics section on surgery issued these guidelines in 2019 that patients with umbilical hernia with some caveats shouldn't be referred to a pediatric surgeon until they're about 4 or 5 years of age. And so here's the kind of thought process is that if you take the fascial defect of an infant, the larger it is, the more years it will take to go away. And so this is a nice graph taken from some paper that was done many years ago. And if you notice, the line stops at roughly age 5 or 6. Why does it stop at age 5 or 6? It's because that's when the surgeons decided that there's a line in the sand that everybody gets an operation after that point. But there's a caveat to this, is you have a small fascial defect when you're 5 or 6 years old. There's a chance that this will still close when you get older. And so here's this very biased surgery paper published in surgical literature that judged potentially avoidable referrals and patients who had appropriate referrals to a pediatric surgical clinic. And you notice the dark blue bars are patients they judged as potentially avoidable umbilical hernia referrals. And you see that this age again appears, 4 or 5 years. So basically, when a pediatric surgeon sees that, at 4 or 5 years is a good opportunity. But here's the reality: what happens is that when everybody has a fascial defect at some size that umbilical vessels have to go through, and over time that closes and gets smaller. And then if you're an adolescent or an adult and have an umbilical fascial defect, it just gets bigger over time. So we have to predict what's the likelihood this will close by the time the patient is an adolescent. And that's the criteria that I think that we should use. And here's some scenarios that I see in the office of patients that are sent to me that I think probably could be taken care of outside of my office. One is that the scenario is that infant comes in, they have an enlarging umbilicus, The kid has a lot of abdominal symptoms or colic. It's blue. The parents think it's going to rupture. It's just getting bigger. There's nothing wrong here. What happens is the skin gets bigger. The ball has a bluish discoloration under the umbilical skin. This is a perfectly normal thing that happens. Second one is if it's ugly. And so it's very hard to reassure a family that this very ugly proboscis is just going to just go away. And sometimes this is a good patient for me to talk to and provide the reassurance that, yeah, this is something that if it doesn't go away, can be fixed. Often, even with this large skin defect, there's a very small fascial defect, and these things will close. And then this is probably the other big category is the umbilical hernia being blamed on abdominal symptoms. Umbilical hernias rarely cause general abdominal pain or other kinds of. If you have pain related to umbilical hernia, it's when it's hard like a rock, hard like a marble, right at the umbilicus. But generalized abdominal pain almost never is caused by an umbilical hernia. So these are criteria that I use for operating. I'll start the discussion about the surgery for the big hernias and for kids that I really have a belief that these things aren't going to close by the time they're a teen. Sometimes if they have multiple reductions that are difficult, so the kid has to go to the emergency department several times to get it reduced, or a stressed parent, then sometimes I'll bend these rules, but I try to be conservative whenever I can. So here's three entities that I commonly see that have some kind of confusion about them. The first, epigastric hernia. These do not need an ultrasound. They don't need, this is not cancer. This is not a tumor. This does not cause abdominal pain. This is basically a small amount of preperitoneal fat that goes through a hole that if you look at the end of the tip of your pen, the hole in the size of the end of the tip of your pen, that's the size of the hole that's there. This is something that can be fixed. If it's not really clear what happens if you don't fix them, but this is something that is reasonable for a surgeon to have a conversation with the family about. Second one, diastasis rectus. This is something that we just don't need to see. This is a normal variant. There's nothing that needs to be done about it. There's no operation. This is not a hernia. And then the final one is something that's just a little bit of a bump above the umbilicus. This is a para or peri-umbilical hernia. These have, when you see these in the operating room, they have this lensiform shape. They look like sort of an eye shape. These are separate from the umbilical stalk. These don't go away. These just get bigger over time. So these generally need to be fixed. So here's the three labels of what these are. Okay, you guys see this all the time, I'm sure. This is the umbilical granuloma and all its different variants. I think that there's a couple things about this. So first of all, common thing that is these things, that the parents come in and there's this yellow stuff that's on the clothing. And is this urine? Is this a urachal remnant? Well, if you see something that looks like a granuloma in the umbilicus, it's an umbilical granuloma. And so I think you should feel free to treat it with silver nitrate. Silver nitrate is the best strategy. Topical steroids can cause skin discoloration, can be more expensive, requires a prescription. If we're in third world countries, there's evidence you could just put salt on this. I think that we should probably use silver nitrate, and that seems to be what's most recommended, and that's what I certainly do. And I use a 3 strikes rule. So if you have to treat this with silver nitrate 3 times, okay, maybe 2 times, then you should give up on it and send it to me to take a look at. And there's 2 entities that are commonly confused or a concern about these 2 entities that the umbilical granuloma might be. One is urachal remnant. Well, you in your career may never see a urachal remnant because the population incidence is astoundingly low. And when it occurs, it's not this sort of like yellow dot on the baby's onesie. It looks like urine coming out. And if it's not clear-cut urine, it's probably not a urachal remnant. And then OMD remnant, that's our fancy lingo for surgeons. We use a fancy abbreviation for omphalomesentéric duct remnant. This is where the ileum has a connection with the umbilicus with protruding small bowel. And it looks like an umbilical granuloma, right? Well, if you look at these, so first of all, this is rare. We don't see this that commonly. And if you accidentally treat this with silver nitrate, nothing bad will happen. In fact, about 1 out of 20 patients ultimately have this diagnosis, were originally treated with silver nitrate or some other strategy as an umbilical granuloma without any harm to the patient. So a couple things. If you're using silver nitrate, put the silver nitrate on, get the flecks of silver nitrate off, and then put Surgi lube or some kind of ointment on top of the umbilicus to avoid the picture that's on the side here, which is a burn with silver nitrate. And then what I do in the operating room, what I do in the office is sometimes I just use silver nitrate all over again. That's why I think doing the 3-strike rule is good, so that you can do those silver nitrate trials in your office. But one of the things that I do is I'll put a suture around the umbilical granuloma to make it go away. We don't want to see this picture on an afternoon. This is pilonidal cyst. So pilonidal cyst is a very frustrating diagnosis for everybody involved, for the patient, for the doctor, for everybody. And let me just give you some general guidance on kind of how to approach this. So the typical appearance is that there'll be some natal cleft pits. There may or may not be hair there. Sometimes you see this you see the picture on the left, you see this area of inflammation. This is where there was an infection that started in one of those hair pits. It tracked up into the side of the natal cleft, and there may be kind of chronic drainage or purulence. There's an arrow over there that shows you kind of a chronic granuloma that's there. And these are all different variants. So what do you do about this? Well, I think there's a lot of things you shouldn't do. So none of these things, so if you have a pilonidal cyst that looks like this, a few pits and this kind of granuloma type area, things that don't work, oral antibiotics does nothing. Topical antibiotics does nothing. An MRI to make sure this doesn't involve the spine, or an ultrasound to make sure it doesn't involve the spine, doesn't do anything. Culturing this, you're culturing an area that's going to have a flora that you can kind of predict what it might be. And actually shaving doesn't do any good. This is a kind of a traditional thing, is you should shave the area. It's a good suggestion for people who are not going to do it. Laser therapy does work a little bit, but shaving probably doesn't work. Now the picture on the right is a patient who needs to go into the emergency department. That patient doesn't need to be seen. It needs to be out of your office, needs to not be in my office, needs to be in the emergency department, so that can be I&D and drained. And so when to send it to me? Well, I think if the patient looks like that picture that I just showed you, it's acutely swollen, it's painful, there's cellulitis, there's clearly an abscess, that patient needs to be seen. And usually we sedate the patient, so it's a good patient to be seen in the emergency department rather than in an ambulatory pediatric surgical office. And then for the patient, the more typical patient, the patient has chronic symptoms. They may have intermittent pain. They may have blood or pus that comes out every once in a while. Those are patients it's good for us to talk to give them counseling on what options they may have. And I usually recommend one of 3 things. The first thing I recommend is doing absolutely nothing, because most of these patients will have self-limited disease. It minimally impacts their life, and any kind of intervention to fix it is worse than the problem that they're coming to see me for. The next level of intervention was called a Gibbs procedure, and this is something that's being more popular for taking care of pilonidal cysts. And basically what you do is take those hair pits and you take a skin punch, you punch out those small hair pits, and then punch out the kind of chronic granuloma and clean out the tract, obviously done with the patient asleep in the operating room. This is a good procedure. It has a 15%, one out of 6 times roughly, this doesn't work and you have to repeat it. But that's pretty good. That's pretty good results. The picture below is the pilonidal cystectomy. That's a pretty morbid operation. about 50%, 1 out of 2 patients will have non-healing of a portion of the wound, but once they get through the healing phase, it's gone. So this is a pretty morbid operation. Every time you sit down, every time the patient sits down, they're pulling the incision apart, and that's what accounts for the problems that you get with doing the operation. So surgery in all its different forms are really reserved for patients who can convince me, at least in my practice, convince me that this is a lifestyle problem for them. This is another diagnosis that I see that has a lot of different strategies for. This is the infant, usually boys. This is much more common in boys than girls, and you have this chronic draining area in the perianal area. Things that don't work for this: oral antibiotics do absolutely nothing. Topical antibiotics do absolutely nothing. And the best strategy here is to be patient with it. Pretty common. Again, mostly males. We really don't know what causes. It's probably some kind of hormonal thing or some structural thing related to the anal crypts. So things that I don't think you should do, again, oral and topical antibiotics, hot compresses, bath soaks. These are all maneuvers that if you want to try something or do something or say you're doing something, I guess are okay, but they don't really affect the course of these. And what happens is that when they're in the fistula phase, they just go through a bunch of cycles. They heal up and they go away, and then they come back and drain, they heal up and go away. When you have cellulitis or an abscess, those are patients that we should see. And I generally try to be less interventional with them. So if they do need to be drained, it's best to drain them with a needle as opposed to do an incision and drainage, because as soon as you break through the skin, then you increase the chance that you're going to form a chronic fistula. I don't give antibiotics for these kids unless there's frank cellulitis. So this patient with the red bottom, I probably would not give antibiotics for. So I give if they have clear-cut cellulitis involving a large portion of the buttocks, or they have high fevers. And so what happens is, so these patients will go through these cycles when they have a perianal fistula. They go through a cycle where they heal, they heal, they come back, they heal, they come back. And here's a distribution of how long it takes these things to go away. And so it's like several months for it to go away. So eventually, if they don't go away, the operation fixes, the kids go to sleep, take a metal probe, put it through the fistula, and just cauterize to open up that tract. This is to flay it open, let it heal from the bottom up. And I use this 3-strike rule. If they come to see me 3 times, then they get an operation. And I think that's a good rule of thumb, because then you have parameters you can tell. The parents of the kids who have this are usually pretty stressed out. So it's good to have some kind of framework. If you come by, you have this one more time, then we're going to talk about doing an operation. Couple comments about hernias and hydrocele. I think there's 2 scenarios that I see in my office that are vexing for me, and I'm sure vexing for you too, is that the parents see something, but you don't see anything. They describe inguinal swelling or scrotal swelling, but you don't see anything on examination. And my clinics are mostly in the morning, and so but the kids haven't had a chance to run around all day. So usually they don't have the swelling that you see. So I just maybe need to move my clinic to the afternoon. And then how to tell the difference between a hydrocele and a hernia. So here's all the tricks to try to elicit a hernia. First of all, taking pictures. So getting a front view and side view. If you don't see it and the family can get a picture, when they come to see me in the office, if they pull out their phone and said, I have a picture, I was like, perfect. Then sometimes the examination isn't needed. I can tell just by the history in the picture. Things that increase the intra-abdominal pressure. You guys know that things that examining the ear is one strategy. Balloons. I have these balloons that nobody can blow up, and I have the kids try to blow them up, but you're not supposed to give balloons to kids, so I take them away. Having the kids jump up and down, or having them stick their belly out. But again, I think that the most useful thing in this of these things is the iPhone. So what's the timing of referral? So very common question I get from parents is, it's just a little baby with a hernia. He's such a small baby. Should we fix this? Can't we just wait? And I think that this chart, this graph shows you why you shouldn't wait. The younger the kid, the more likely incarceration is to occur. So if you're less than 6 months old, your incarceration risk may be as high as 30% or so. As you get older, your incarceration risk goes down. So I think the kids less than 6 months, urgent referral, be seen in a week, maybe outside 2 weeks. But I think this is the rationale of why infants should be seen sooner rather than later. So hydroceal's super common. I think that there's several kind of formulas you can use to try to figure out what to do about these. So first of all, figure out if they're communicating. So how do you know if they're communicating? They're communicating if they're fluctuating in size. Now, I don't mean like a little bit, like you're not sure if it fluctuates in size, but it gets really big and then it goes away completely. So that suggests there's just a communication with the peritoneal space, that there's a small hernia, and that's something that won't go away and needs to be fixed. If it's symptomatic, and hydroceals don't cause abdominal pain, they rarely cause inguinal pain. But if there's a remarkable history that parents can convince you it's symptomatic, then that's something that we should talk to them about. Or if it persists, and let me give you the recipe about persists. So if you look at the age of presentation, that's on the x-axis, and you look at the age that it goes away on its own, you can see it kind of has this line. And so if you now take that line and draw a 2-year line above it, okay, so in other words, wait 2 years, you can see that all the dots are underneath that 2-year line. Does that make sense? So if you wait 1 or 2 years from the time you first see a hydrocele that's stable, that's not communicating, that's not symptomatic, most of those will go away. So you can use a rule of thumb. If it's 1 or 2 years, you can wait to send them to me. A couple of things I don't think you should do. I don't think you should ever put a pen light on the scrotum. If you have bowel in a hernia, it will also transilluminate. So it's a completely unnecessary diagnostic test. And then ultrasound. If you're at a point where you believe you need to get an ultrasound to help figure out what's going on with something, send them to me or one of my colleagues, because I'd want the chance to do a physical exam and history and see if I can make the diagnosis just using that information. And finally, I'm going to finish with lumps and bumps. Very common thing. So lots of lumps and bumps out there. I probably have lots of lumps and bumps on myself or on my kids. I don't know. So this is a good kind of recipe on how to figure out what to do. So there's some risk factors you can identify. If it's been there since the kid was born, if it's growing, if it's fixed to the fascia, not moving, or it's big, it's firm and it's big. Those are, I don't think I need to tell people here. Those are kind of, those are risk factors that, that this might be a malignancy. If you don't have any of those criteria, the chance of this being something bad is less than 1%. So once you throw out all those risk factors, then you can be reassured pretty confidently that these are benign. Now I'm throwing out the lymph nodes, which is a whole different discussion. Now, if you take all the ones that have these benign characteristics, about 1 out of 20 of these will go away. Dragging your feet, providing reassurance are good strategies to avoid doing things that aren't necessary. And then this is my final slide. So, looking at this is a nice paper from Pediatrics that looked at how best to get the best referral care for kids, for pediatric surgical services, for any kind of referral services. And they looked at like what are the features of the patient interaction that make it difficult. And there's some demographic factors that you can see listed here, but two factors which I think are important to consider is a long distance to the referral person and a longer interval until the appointment. And so, finding your local pediatric surgeon, and we are pretty available actually. You can see us easier than a lot of specialties. We can usually see somebody within a couple of days or a day. That certainly helps the patient and prevents the dropout for the referrals. And I have a lot more slides, but I'm going to stop there. All right, thank you for your attention. Under time, didn't I?
Did great. Thank you, Dr. Burd. We have a question online. Get on the microphone. Okay. Thanks, Dr. Burd, who is repeating.
I won't operate on less than a year of age, mostly because the anesthesia risk, more or less, you can make that as your dividing point. But I'm happy to see the patient anytime around that point. If you send it to me at 6 months, I'll just wait until to do it when the kid's over a year.
Can you just repeat the question?
The question was, with a periumbilical hernia, what's the age you should refer? And what's a related question would be like, what age would you operate? I'd wait till the kid's over a year of age, and I'm happy to see the kid at any point around that time.
Thanks so much, Dr. Burd. And thanks for willing to be the last car on the train for a full day of CME program, but we really appreciate you ending with a surgically precise presentation. It's great.